Hi, Jennifer.
Fantastic. Thank you so much. So I'm Jennifer Taylor. I'm an associate professor in the Department of Environmental and Occupational Health. Welcome to this wonderful seminar. Laura Punnett is a distinguished university professor of epidemiology and occupational ergonomics at the University of Massachusetts at Lowell. She's a senior associate at the Center for Women Who Work, and her paper, To Be the Fairest of Them All, encouraged us to look at the context of sex and gender in occupational safety and health research. She's the co-director of the Center for the Promotion of Health in the New England Workforce, which is a NIOSH Total Worker Health Center of Excellence. And her recent work really illuminates for us a new frontier in public health scholarship, and that is to think about the dissemination and implementation of our research, the uptake by communities. How do we know that our research is making a difference and is making a measurable impact with communities? In all these roles, Dr. Punnett has worked with nursing home employees, apple pickers, construction workers, drywall installers, and those who fish. An ergonomist by training, she also has expertise in assessing the importance of socioeconomic influences on occupational safety and health, like work-family conflict and work-family balance. Her work in these areas encourages us to pay attention to the organizational structure of our work environment. An accomplished violinist, Dr. Punnett plays with the Melrose Symphony Orchestra. While she did not bring her violin today, she did bring her incredible career of making a difference in occupational safety and health. Today, I'm excited to have her here because she's going to be talking about a persistent but relatively under-recognized toxin at work. Unlike things in our air, water, and soil, which we've really started to get a handle on, there's another thing that's the new occupational toxin, and that is us. Colleagues, ladies and gentlemen, Dr. Laura Punnett.
Thank you so very much for that kind introduction, Dr. Taylor, for inviting me, and to Dr. Fagliano as well for hosting me. I'm not sure I can live up to all of that, but I'll do what I can. I'd like to thank Dean Diaz-Ruz for the honor of this lecture, and to Diana Marshall, who I think isn't in the room right now, for taking such phenomenal care of me today. I'm no good at catchy titles. I have to apologize that this one is so unwieldy, but it does give you a view of where I'm going with this talk. I don't know what to do differently. What should I do?
Stand farther away, maybe.
Okay.
Feedback.
I know. Okay, so you think I should stand back here?
Yeah.
Okay. Where? Okay. I'm here. I think I'm going to have to stay with that mic. I don't think this is going to work. All right. We tried.
It's weird that as soon as you take it
I
off,
know.
it's fine. But
I know. It doesn't like me. Somehow it doesn't like me. Yes, we were trying to make it possible for me to wander around the room, but I guess I'm going to have to stay in one place. So I'm going to be sharing with you the results of almost 13 years of work under this umbrella, which is the collective effort of easily 30 faculty members, research staff, and students. It would take a whole slide to put all their names up, and you wouldn't be able to read them. But obviously, this is, you'll see, has been a very ambitious effort, and with many components that different people have contributed to. So, total worker health. What is this all about? We'll start there. So, it was developed as a concept to address a division between two important areas of public health. that really don't talk to each other, even though they both are carried out in workplaces. One is the field of occupational safety and health, which is what I was trained in, which is about reducing hazards and exposures in the workplace that lead to injury and illness. And the other is the field of health promotion, which is typically oriented towards reducing what might be referred to as lifestyle factors that are involved in the development of chronic disease. And parallel to the gap between these two disciplines, there's also something of a gap or I'm going to argue in a few minutes, kind of an artificial distinction between health outcomes that are attributable to work and health outcomes that are unrelated to work. So NIOSH is the National Institute for Occupational Safety and Health. It's part of the Centers for Disease Control. And it is the federal agency which is responsible for research and education and training on occupational health and safety. So its traditional scope has been the first of those silos that I showed in the previous slide, the prevention of hazards and exposures in the workplace in order to avoid injury and illness. So NIOSH in 2005 said, well, perhaps we should expand our mission a little bit. Perhaps we should think about ways that workplace health promotion could be integrated into that effort. Here are these two professional areas that are both active in the workplace. Could we have more efficiency and more effectiveness if we combined them, if we promoted their integration? And partly this was coming out of people thinking about socioeconomic disparities in health, the fact that low-wage workers in particular end up with the most strenuous or hazardous jobs and also face typically the biggest obstacles in the community outside the workplace for being healthy, for maintaining a healthier life. Well, what really resonated for me in that funding opportunity is something that I had been looking at for a while already, which is the extent to which socioeconomic status is related to job exposures, job hazards. So on average, there's a very strong trend across our economy that lower socioeconomic status jobs involve fewer opportunities for decision making at work, for just regulating your own work day, more physically strenuous jobs, more exposure to safety hazards, more exposure to chemical hazards. And again, being of low socioeconomic status also implies potentially fewer opportunities for purchasing healthy foods in your neighborhood, having safe places to walk and exercise, and so on. And then coupled with that, and part of what NIOSH called out, is the reality that workplace health promotion programs often, even if they're offered to all employees in a workplace, will end up with higher participation from higher status employees. The people in the office who can arrange their work to get off for a little bit, the people who have more access to communication because it's coming through the computer, and less effectiveness among the lower socioeconomic status employees. But if you step back to what health promotion really is about, the World Health Organization issued this document over 30 years ago, talking about health not as something that we go out and tell people to do, but rather as the result of preconditions in our society. So if we have a peaceful society, if we have access to reasonable shelter and education, adequate income, good quality food, a stable ecosystem, and so on, then we have the preconditions that make health possible. So it was a very macro level view of what does it mean to be healthy. It means living in a society that makes it possible to be healthy and that promotes our well-being. And if you kind of dig down into this document a little bit, as I encourage you to do if you aren't familiar with it, there's reference to removing obstacles to health from many potential sources, and about creating conditions that foster positive decision making. So again, it's not about telling people what to do. It's about making it possible for us to live in healthy ways. And so there were elements of this, again, that really resonated with the idea of reducing socioeconomic disparities in health, providing environmental conditions that are safe for people, offering positive human relationships in the community and at work that foster decision-making and self-efficacy. I hadn't thought of myself as someone who did this kind of work up until this point in time. And then these pieces started to connect, which was exactly NIOSH's goal. So, okay. Together with a number of colleagues, we developed a proposal for the Center for the Promotion of Health in the New England Workplace. And we framed it around studying interactions between work and non-work threats to health, evaluating strategies for integrated interventions within workplaces, and identifying opportunities for making these kinds of programs happen and also obstacles to them. And so this is my spoiler alert, these key take-homes. Work organization as a source of risk factors for chronic disease, participatory intervention processes, and the concept of a health-promoting organization. The salutogenic organization is a phrase of our colleague Georg Bauer in Zurich. So the idea that the workplace could be a source of health rather than an obstacle to health. So these were some of the sort of founding principles that we incorporated into our work. And NIOSH, over time, evolved its thinking as the research has deepened. So actually, if you go on their website now, what you find is not about workplace health promotion programs, but rather more broadly, integrating protection from hazards, but more broadly, prevention efforts to advance worker well-being. And I'm particularly proud of this last phrase: risk factors in the workplace can contribute to health problems previously considered unrelated to work, because this is exactly some of the research that we've been producing, as have others. And that's actually where I'm going to start with our particular story. So we had the opportunity to partner with a large long-term care company. At the time that we were working with them, they owned about 200 skilled nursing facilities up and down the eastern United States. And they had implemented a safe resident handling program in order to reduce the incidence and cost of low back injury, especially among the nursing aides handling residents in their nursing homes. We conducted actually a series of 6 panel surveys over a number of years, self-administered questionnaires in the workplace. Initially, we targeted only the clinical staff, and over time, we expanded that to a broader scope. I'm not going to tell you, actually, so the Safe Resident Handling Program turned out to have a lot of really great outcomes, and we have a ton of publications about that. But I'm going to skip that part of the story because I want to show you some other things that we did with the data that we were able to collect. So we looked at several selected health behaviors. This one is taking leisure time inactivity, right? Not getting out to walk or run or kayak or whatever it is that you like to do outside of work hours. Inactivity among the nursing home staff who responded to our questionnaire survey. We took that as the outcome. Usually it's treated as a predictor of disease. Here we said, okay, we already know that exercise is good for you, right? Let's see what are some of the factors that might be associated with being active or not. And we constructed a scale of occupational hazards. These are listed at the bottom: low decision latitude, low coworker support. These are some of the classic psychosocial stressors in the occupational health literature. Working regularly at nights, work-family imbalance, and a perception that management tolerated discrimination among the workforce. So we took a score. The more of these you reported on your survey, the higher your score was, and you can see that there's a bit of a trend here, that people experiencing more of these stressors at work were less likely to be getting leisure time aerobic activity. And this is just the raw data, but we did some fancy modeling, adjusting for gender and education and so on, and found the same results. And then we also looked at whether this relationship varied among subgroups. So this one didn't, but the risk of obesity, as you can see in the first set of bars, there is a, let me test this and see if it works. Yes, so in the first set of bars, this is for the whole survey population, and the scaling is different, but the association is about the same. But it turns out that actually a lot of that effect is limited to the younger employees, suggesting that in the older part of the population, body weight is more fixed. It's not so easily changed. It's not going to be so affected by current working conditions. It may be a result of past working conditions, but it's not so sensitive to current working conditions, whereas in the younger employees, there was, as you can see, a very striking, you could say, dose-response relationship between these types of stressors in the workplace and being overweight. And similarly, the risk of smoking was associated with a similar set of stressors at work, and again, more sensitive to, the younger workers were more sensitive to the effects of those kinds of stressors than older workers. Again, suggesting that at some point in life, one's smoking habits are established, and that's not the place you go to if you're feeling stressed, but that in younger people there was greater sensitivity, which has a lot of repercussions, I think, for our long-term costs and disease burden in society if we're setting up these kinds of impacts in the younger people in our workforce. The other large project we've been doing is with employees in corrections facilities, correctional facilities specifically run by the Connecticut State Department of Corrections. So this is one small bit of that work, and I'll come back to it later. This, similar to what I showed a couple of minutes ago, this is taking physical activity as an outcome and showing that workers who reported more burnout were less likely to be exercising outside of work, whereas those who had more job satisfaction were more likely to exercise, and those who experienced high coworker support were more likely to exercise. Burnout had a similar effect on the intake of fresh produce. So people who were more burned out were less likely to be eating fresh fruits and vegetables, and they were also sleeping less and having worse quality sleep. So these are all outcomes that tend to be thought of, again, as lifestyle factors, but here are these associations with working conditions. So to reframe a little bit what Dr. Taylor said a few minutes ago, I think of job stress as a take-home toxic. I think of job stress as something that people do not leave behind when they go home from work. People go home and ruminate. It impacts their mental fatigue. It apparently impacts a lot of behaviors and a lot of their experience outside the workplace. It's not just left behind when you leave. It also turns out that other people started to be asking some similar questions around the same time. So I'll give you just a couple of examples. There's by now a fairly voluminous literature, but this is a Japanese study in which they surveyed employees on 2 different occasions, and on each occasion they classified people as having low or high. So job isostrain means high demands, low decision latitude, and low social support. So they classified people as being low or high on each occasion. So and we see separately for men and women. The blue bars are the people who had low job strain, both at baseline and at follow-up. They're our reference group here, so their relative risk is 1, and we again see a trend with exposure on 1 survey or exposure on 2 surveys to this standardized set of job stressors. And then this is another study, completely different British study using similar measures with 3 survey occasions now. And so again, we can see that there's essentially a dose response trend. So the more occasions in which an individual was reporting job strain, the higher the probability of obesity, whether you define it in terms of body mass index or weight circumference. And it's even gotten to the point where there are starting to be review papers. So this is one looking at job strain, psychosocial strain, and smoking, restricted to prospective studies, evaluated on methodologic features, so a fairly rigorous review showing that high job demands were associated with smoking more per day, higher probability of relapse after cessation, I think higher attempts at cessation, but higher relapse, having more resources at work, job control and other supports, led to smoking less per day, higher cessation, less probability of relapse, and having more social support at work, less smoking per day, more cessation, lower relapse. So again, the influence of the work environment on something that we don't tend to think of as work-related. So this is a fairly standard set of measures that are characterized as indicators of psychosocial strain at work or stressors at work. Low decision latitude is the single most important feature, not being able to decide how you carry out your work, not having any flexibility, not being able to use all the skills that you bring to the workplace. We're here in an institute of higher education because we're hoping to move into jobs with more decision latitude, where you get to be exercising some autonomy, learning some new things, having room to make mistakes and learn from those mistakes. The high job demands, both rapid work pace, time pressure, conflicting job demands, these can be both psychological and physical in nature. They aren't necessarily the worst thing for health, but the combination of high job demands and low decision latitude is widely recognized as being extremely important. It's associated with a vast number of cardiovascular outcomes, including incidence of myocardial infarction and rates of fatal strokes and so on. Low social support, I had mentioned earlier, actually includes within it both instrumental support, helping your colleagues get the work done, and also and quality of supervision if it's the supervisor support, as well as people getting along well and friendly and expressing concern about each other. And then some people also include in this standard set feeling not fairly rewarded for the effort that your job takes. And again, this set of stressors is associated with a variety of chronic disease outcomes, heart disease, diabetes, and others. And actually, there was a very interesting paper a few years ago talking about mechanisms of this association, because we mostly interpret this association in terms of allostatic load, adrenaline and norepinephrine and other hormonal mechanisms. But the authors of this paper said, in fact, the action of these stressors at work through health behaviors like exercise and smoking and diet and so on is a very important pathway which potentially accounts for about 1/3 of the impact of job stress on heart disease, which is not something that's still commonly recognized, in fact. I find when I talk about this literature that a lot of people still are not so familiar with it. So we took these kinds of findings and we thought maybe we could dig into them a little bit and sort of unpack what's going on. And we did a qualitative study. We did a focus group study of low-wage workers in the Boston area, Latino and African American, recruited through community organizations. And we asked them, we didn't pick people based on how big they looked. We just asked them to come and talk to us about how the job might affect diet and or exercise. And really the only requirement was they're willing to talk about that and they had had a job within the last 12 months. We conducted 8 different focus groups, as you can see, with a wide range of participants and in a wide range of jobs. I knew what we were going to hear. I expected to hear things like, I have to race home after work to get my kids, so I stop at McDonald's to buy food so that we can all eat when we get home. I expected to hear, I'm really tired when I get home. I've spent all day on my feet, or I've been lifting and carrying, I'm physically fatigued, I don't feel like eating, or I stuff food in my mouth because I'm so fatigued. A lot of people talked about time pressure and feeling stressed and compensatory eating. People talked about having to eat quickly. There just wasn't enough time for a regular meal. We heard quite a lot about the way the work is scheduled within the workday. So one gentleman told this very poignant story about how he used to play soccer with his friends on Sundays and they would all get together and cook afterwards, and now his days off are Tuesday and Wednesday. So he has none of that social, physical exercise, and his opportunity to sort of stop and have a pause point in his week is gone. A lot of people talked, these are low-wage workers, and these are not generally people who are sitting all day. A lot of people talked about their rest breaks. Quite a number of people said, I get the 30-minute lunch break that's required by law, but I get it in 2 chunks, 11 minutes in the morning and 19 minutes in the afternoon. Neither of those is long enough to eat a salad or to heat up my food in the microwave and then sit down and eat. So I'm grabbing food out of the vending machine. I'm grabbing candy bars out of the vending machines. I'm bringing things that I can eat really quickly. A lot of people reported to us, I don't know when I'm going to be able to eat during the workday. I come in the morning and I have no idea whether I'm going to get my lunch break at 11 or at 2. So when I can eat, I stuff as much food as I can in my mouth because I might be really hungry before I get to eat again. I had no idea that these kinds of things were, in fact, not uncommon practice. So we took this understanding, we were still doing the nursing home study. So we took these insights, these lessons, and we converted them into 3 new questions that we added to our survey. Do you have enough time to eat during the workday? Do you know in advance when you're going to eat? And do you get to eat when you want to? Which seemed like, to me, fairly sort of fundamental self-determinant characteristics. And these are now more than 2,600 respondents. About 60% of them are nursing aides, and the others are in a wide variety of jobs within the nursing home. So at this point, we were surveying the laundry workers and the cleaning staff and the nurses and the secretaries and pretty much everybody we could find. So you can see here that these blue bars are the people who said always or usual. So we've got 50, 60, 50 something. In other words, between a third and almost a half of this population with a fairly routinized work schedule were saying sometimes or rarely or never to at least one of these questions. And we actually constructed a score of these 3, which we're referring to as meal unpredictability, or I haven't quite decided, but something like that. And it's higher among the people who work on night shifts, and it's higher among certain job groups than others, and it also is somewhat associated with intake of fresh produce. But even so, to me, it kind of represents a sort of a basic, again, sort of human right of how do we organize our own eating intake. I'm someone who grazes all day, so I would really hate to be forced into a schedule of the sort that people were describing to us. And the other thing that really came out of that focus group study was a very strong reminder that if we don't ask people what's going on with them, we may not be able to imagine, especially if we have a somewhat privileged position as a researcher looking at a workplace from the outside. We may not appreciate what the struggles are that people are having with fairly basic aspects of their job. And again, it's often the people in the lowest status jobs who are the most affected. But we aren't necessarily going to see all of what's going on. We may see the heavy lifting, we may be able to measure the chemical exposures, but we're not necessarily going to see the mandatory overtime or the work-family imbalance or the financial stress they're experiencing, which might lead them to work 2 jobs in order to keep food on the table. So these things all have a very profound effect sometimes on people's health and well-being. Dr. Taylor works on firefighters, so I went to some work of some good friends of mine who have been studying firefighters in Southern California, Marnie Dobson and Bangkyu Choi and Peter Schnall and that research group. I thought it would be appropriate to bring that in as well. So they have also been looking at job features and health behaviors in firefighters. And so this is a very particular work setting, actually not so different in some ways from from corrections. It's sort of like baseball, actually. You have long periods of waiting, and then you have very high energy output with potentially a lot of adrenaline and stress associated with it as well. So they identified a set of 6 factors over a series of several studies: fire station eating culture, night calls and sleep interruptions, supervisor leadership and physical fitness, kind of modeling by the supervisors, the fact that they are sitting a lot of the time, and then age and generational influences on the food practices within the fire culture. It's also really important to note that they work 24-hour work shifts, and sometimes they have double shifts. So sometimes they actually are at the fire station for 48 hours. So this is their living environment as well as their work environment. And they also found a fairly defined set of working conditions, including the unpredictable work pace, the very long work shifts, the role of social relationships at work, job strain, and so on exercise and on diet patterns. So qualitatively similar findings to ours. So the understanding of the importance of asking people about the context of their work and collecting this kind of qualitative data, which is so vital to understanding the quantitative relationships, this also underpins our commitment when we develop intervention programs to a very participatory process, involving employees in doing root cause analysis, in brainstorming solutions that are feasible within the constraints of their work and life situations, and teaching them the skills to make a business case to management so that they have some credibility in what they're proposing, and assisting us in evaluating what the outcomes are. And I think there are a lot of arguments for participatory process. Hopefully I don't have to persuade you of those. There's both a pragmatic one about getting their knowledge, learning from them in the ways that I was just talking about, and there's also an argument of principle that, I mean, I wouldn't like it if somebody came in and started messing around with my work environment and didn't ask me what I thought, and I think it's only fair that if I'm going to start proposing changes in a workplace, that's a process that gives people an opportunity to participate in it as well. So I'm a really strong advocate of the idea that the process of how we introduce change is as important as the content. And I would say this is especially true because the lack of decision-making opportunity is already a stressor in a lot of people's lives. So we don't want to be making change in a way that makes people feel even more disempowered. If we can start on the principle that we're going to be increasing people's decision-making opportunities, giving them, creating a structure where there's a role for workers to be involved in the process of bringing about change, then maybe we can reverse at least some of that feeling of being disempowered, of having no opportunities to participate in decision-making that can be so frustrating and so stressful. So I think this is a public health school where I think the concept of community-based participatory research is taught and understood, so I'm not going to go into detail. It's definitely one of the literatures that we have relied on heavily in thinking about what's the right way to do this. But there are some caveats when you take that model and you apply it to the workplace, because there's such an inherent hierarchy about who has the resources and who has the decision-making power. And there's not an equitable distribution of access to resources. Confidentiality is not always guaranteed. Membership in the community is not always guaranteed. People can often be fired at will, including for participating in the process and saying what they really think about what's going on, sharing information that researchers might be asking for. So it's a valuable model, but it has potentially some limits when applied to the work setting. Another literature that we've relied on heavily is that of participatory ergonomics. Traditionally, this has a specific focus on workplace organization, but to benefit safety and health in more perhaps concrete ways, and also looking at efficiency and quality so that the overall system functioning. It's a widely used approach within my field, and there's a lot of experience and a certain amount of accepted structure for how you go about doing this. But it's a little bit limited in terms of the topics that are generally taken up, so it tends to have a focus on musculoskeletal disorders and physical safety issues. If we're going to use it under the total worker health umbrella, which is where our funding comes from, then of course we have to give a broader scope to the process. But these two together have been very useful pillars for the approach that we've developed. And again, we have a really primary focus on trying to increase decision-making opportunities, which the ergonomist learns about. The ergonomist, in part, we don't just study how high should the table be or what should the weight limits be on lifting a box, but also what are the ways in which work organization determine employee autonomy, opportunities to use one's skills at work, what are the best ways to schedule work schedules, how does work organization either positively or negatively influence social relationships, what is the feedback system, what is the reward system. These are all part of what fall under the field of occupational ergonomics, and I could give you a lot of examples if I had another hour. So we take a big system level view, and we think about potential changes at all of these levels. So we're not just focusing on individual behaviors, but we're looking at potential changes at the level of the supervisor or the work group, of the physical work environment, and the overall organization. The model that we've developed is called the Healthy Workplace Participatory Program. It's available on our website. Your tax dollars at work, if you pay tax dollars, have produced a large number of training materials that go with this. The basic concept is that we create or we work with a design team. This could be an existing health and safety committee, or it may be a team of workers who step forward and volunteer for this activity. We call it a design team because the emphasis is on moving forward towards positive change. And we provide training and facilitation of the design team. We also concurrently train top leadership in the facility, the people who have authority about over the purse strings and on all of the resource allocations, like whether workers can have an hour off to participate in a team meeting. We teach people to conduct root cause analyses, to develop integrated interventions that try to address the scope of what's been raised in that root cause analysis. And they brainstorm with us what would it look like if we had achieved the outcomes that we want, and those become our key performance indicators, which they then work with us to evaluate. And we have a very well-developed structure for what the design team does and what the steering committee does. The facilitator plays a key role in setting up the communication structure between the two groups, although there's lots of informal communication as well. And we have a planning method, which is like your basic think, do, act kind of wheel. Begins again with the root cause analysis. Begins again with the root cause analysis and goes through setting key performance indicators, selecting the steps to implement, evaluating, and then going through the process again. And then in terms of the communication between the design team and the steering committee, this also is laid out in a very structured way, so the top management knows they're not going to hear from the design team for a couple of months while we're doing a lot of training and getting the first brainstorming process started, and then the communication between the two groups becomes much more active. So this is a field-tested method. We've been using it for quite a while. This evaluation is a qualitative one that comes from a real estate management company, one of the first sites that we worked with. The design team members, the workers, the maintenance workers who were involved in the design team, were very pleased with the fact that they were provided with a structure where they could give feedback to management, which they hadn't had before. And they were especially pleased that this wasn't just a gripe session, but that there was actually a structure for making change happen. They identified that change both in terms of concrete problem solving with health and safety issues that they experienced, including heat stress and time pressure. And they also felt more respected by management as a result of the structured communication systems that were created. Management was also very positive about this process. They had some new understanding of what the workers were going through. They liked the materials that were produced. They had, I think, an increased level of respect for the capability and the understanding of the people who worked for them that they hadn't had before. In our corrections work, so again, this is a very challenging situation to work in. There's a tremendous amount of mental stress in corrections work. It shows up in a whole variety of health outcomes. The life expectancy of Connecticut corrections officers is 12 years less on average than other state employees adjusted for age. This is a result of heart disease, depression-related issues. There's suicide, notable rates of suicide among corrections officers. There is take-home domestic violence, alcohol abuse. It's a really challenging situation. We put people in jail and then we put other people to guard them, and it's a really crummy scenario. And even though they have to pass physical fitness tests to be hired, within 2 or 3 years of employment, their health profiles are deteriorating quite notably. So they themselves identify some of these issues as really high priorities. Obviously, some are easier to tackle than others. We have been working with them for over 10 years now, and there's been a long period of building relationships and building trust and sort of digging deeper into the issues. So just a few kind of skating on the surface. The Healthy Workplace Participatory Program has been used to address helping people plan for appropriate nutrition. If you're coming in to a prison and you have to bring all of your food with you and you don't know if you're going to be tapped for a second shift, consecutive shift, or potentially even a third shift when they had to stop hiring new recruits for a little while, you bring in an awful lot of food to work. And then there's a tendency to eat it all before you go home again. So just learning to plan what's an appropriate amount of food was a useful skill for people. We had a remarkably successful intervention around indoor air quality. The handling of difficulties among personnel was a huge issue because there's a system for formal filing of complaints over even fairly small altercations between personnel, which starts a downward spiral that's very destructive because you have to rely on your coworkers for your physical safety. You can't afford to show weakness in front of your colleagues, and you also can't afford to show weakness in front of the inmates. So the amount of mental and emotional stress that gets stuffed under the surface is phenomenal and is what leads to a lot of the health outcomes that I was talking about earlier, we think. So a new process, being able to develop a new process that went around those formal complaints was very useful. The COs have carried out and designed and carried out several health promotion programs for themselves. They developed a peer mentoring health program for new recruits. The CO supervisors said, how come we're getting left out? We want in on this too. They created a parallel design team for themselves. And actually the Commissioner of Corrections for the state of Connecticut keeps saying, no more control groups. We have to take this whole process statewide, which is pretty exciting. So the peer-mentored corrections officers have had measurable improvements in their health outcomes. The CO supervisors identified sleep problems as an important issue and developed a smartphone app that they are all using now and which is being actually picked up for national use within the sector. This is a really difficult group to work with, corrections officers, for a lot of the reasons that I've been mentioning. So we're really impressed by the progress that's been made here. So I'll just sum up by saying if we're concerned about the sustainability of the population, we really need to think about work. Those of us who have jobs spend more hours at work than we do, more waking hours at work than we do anywhere else. The work environment has a huge impact on our health and well-being. And the opportunity to make a workplace health promoting is a really important opportunity to develop and take advantage of. Again, I think I've made all these points fairly strongly already, so I won't belabor them. I will say this kind of research is challenging to do. It can be hard to sell it to reviewers. Participatory interventions are very time-consuming, very labor-intensive. You don't always know where they're going to go. The people you're working with may come up with a completely different idea for what their highest priority is than what you thought the priority should be, and so you have to be prepared to be flexible and to respond in good faith to that input. It takes a lot of different kinds of data collection to do an adequate evaluation because we really have to understand the process of why things work the way they do or don't work the way they do. We don't find that a black box kind of randomized controlled trial model works very well for these sorts of interventions. For starters, we can't blind the control group, that's for sure. They know if they're participating or not in the process. But the iterative cycles give us a lot of understanding of what works and why, and helps us to, at least qualitatively, characterize what other contexts would we be able to generalize to with the lessons that we've learned. we were talking a little earlier today about the whole question of attributing impact. If you see positive changes within an organization, can you claim the credit for that? And that's also a thorny issue when you're not doing randomized clinical trials. But there are a lot of people thinking about this within policy circles. So that's another direction that I'm trying to build up my skill set. NIOSH is a research to practice institute, so in addition to doing the research, we're supposed to disseminate whatever we can that's useful from it. So our training materials are all, again, publicly available on our website. We have an online survey of organizational readiness that guides the beginning of the process. We have worksheets and reference guides for facilitators. We have a large number of professionally produced training videos. And you can find all of these on our HWPP website. So thank you very much for your attention. Again, it's really a pleasure to be here, and I welcome any questions. Yes?
Two questions. You didn't discuss the role of unions in these efforts.
Right.
You could talk about the role that the unions have had and how that might have complicated or facilitated your efforts. And then the second question I had concerns sustainability. Do you find that these programs are able to keep going over time?
Yeah, those are both really important questions. And actually, they're not unrelated, as it turns out, at least in our story. The nursing home project, most of those nursing homes were not unionized. It was hard to tell, how that would have played out if they had been. We did, at least the facilities where the facilities where we ran the participatory design teams were not unionized. We did collect some data there were some unionized nursing homes within that company. We did collect some data there. We didn't find obvious differences in workload measures or health indicators between unionized and non-unionized centers, and we took that down to a fairly small set from the same geographical region and didn't find big differences. I do think that, I think there's no question that unions provide some degree of protection for people actually sharing their honest opinions, protection against reprisals, and so that I would not discount, although we didn't have the opportunity to compare that directly. In the 3 nursing homes where we ran some of our very first participatory teams, at the point we had agreed with management in advance there would come a point where our funding structure would require us to back out. We had done a fair amount of skill transfer. We thought these teams would continue on their own. And in all 3 of those centers, for different kind of micro-level reasons, the administrator reshaped the team once we were no longer there on a regular basis. Whether a union and union representation would have prevented that from happening is hard to predict, but we knew that the worker members of those teams were not happy about what happened. The corrections facilities, that is a unionized workforce, and that has been absolutely essential in assisting with keeping the study going through difficulties with the state budget in Connecticut and with maintaining a structure. In fact, it's been an unusual degree of labor management collaboration around this project. They themselves decided they should create a statewide steering committee that would be responsible for all of our project activities in any prison within the state, and it's that union management group that's now talking about upscaling it to a statewide effort. Our new healthcare project, which I haven't talked about at all, is in public sector, state and federal healthcare facilities, and those are also unionized workplaces. And the unions are certainly key players in that. Yeah. So yes, and sustainability, again, I think has, again, there's a structure to support sustainability as well from the unions, I think. That's my personal opinion. Yes?
Thanks for your talk. Since you take people where you find unhealthy or unwell vocation, related to vocation, you can't take them and study them in a new vocation, right? That would be sort of ideal. I'm wondering about the ability of populations from whence they hail, that their ability to be resilient in workplace context doesn't push the interventions further upstream. So specifically, if you find, have you matched populations such that demographics are as close as you can get, except for vocation, and seeing how people do? Do you understand what
There's
I'm
a
asking?
very substantial literature using national data where people are compared on the basis of job title and job characteristics, adjusting for age and gender and education. Yes, a whole range of different demographic factors. I mean, you're right, people don't randomize into jobs, right? We end up where we are from some complex mix of education and personality and opportunity. So it's never going to be the same as taking mice and randomly sorting them into bins. But the epidemiology and the surveillance data, those data sets are big enough that you can adjust on a very large number of variables simultaneously, and we do still see differences by job. Yeah. Thanks for that question. There was yes.
So I was on the Pathways to Prevention panel.
Okay. Yes. That got this whole thing started.
Yeah,
Yes.
for NIOSH and NIH, and my recollection was that there was a lot of pushback from labor groups in this idea of total worker health, and trying to implement total worker integrated interventions in workplaces, because you would identify workers as being unhealthy, and then that could have implications for particular workers. I mean, that was one of the main issues. And so I don't know if you had any pushback. I mean, kind of what Jim was talking about, the unions and everybody else got pushback from some of these labor groups in your work or in your colleagues' work.
We haven't had that kind of pushback to the programs that we're promoting, but NIOSH has gotten that kind of pushback. One of the issues is the one that you raise, a concern about confidentiality of employee health status, and ensuring that that's not violated in the course of carrying out these projects, which is a very real issue. The other issue that the unions have had is NIOSH is the only agency that does research and education around the traditional hazards and exposures in the workplace. NIH won't touch it. If you say anything about occupational anything in a grant application and try to send it to NIH, it'll come to NIOSH, which is tiny in terms of funding, tiny. So the concern of the unions was, are we going to lose support for looking at all of the other hazards that still need attention, that still need more refined epidemiology, that still need intervention studies, and is that money going to be shunted over to health promotion programs when NIH does that already? So that was a really big concern about the portfolio that NIOSH can support with very, very limited resources, and was it going to be diluted, or was the traditional focus going to be lost? That dialogue's still going on. There's still, you can still set up meetings on a national level where that conversation is happening. I think unions, although they represent a very small proportion of our workforce, they're doing a good job about making sure that those issues don't get overlooked. There are 6 total worker health centers around the country, and they're doing really different things. We're kind of in a, let 100 flowers bloom stage of total worker health. Nobody's got a single right model of what this should look like. The work that we're doing is not the same as what any of the other 5 centers are doing, and so what a union's reaction might be to some of the other work, I can't say. But that's a great question, yeah. Thank you for raising it. Yes?
So getting back to your observation of the workers who had a split lunch break, is that strictly lawful? And if it is, do you see it as a low-hanging fruit in terms of policy target, or not so much?
Well, I'm embarrassed to say we haven't tried to do anything about it. I guess it would be potentially addressable either at a city level or at a state level. It is legal. You're required to provide 30 minutes during the day. It doesn't say 30 minutes all in one increment. Would never have occurred to me that you wouldn't provide it all in one chunk of time, but apparently it's occurred to a lot of other people that you don't have to. But that would be a great action research effort. Yeah, we were having a good lunchtime discussion about public policy and not to shy away from that when that's where our research leads. So I think that's an example. Yes, please.
What advances have your program made for correctional workers in terms of the psychosocial determinants of how they interact with inmates?
Oh, that's yeah. Now, I probably not very much yet. The corrections workers themselves, the corrections officers, are fully aware that a lot of people who are in prisons really need mental health services and shouldn't, that's not the right environment for them. I don't know if it's the right environment for anyone, but certainly that there are lots of people who need mental health services, and that the population that they are custodial for is quite diverse, and that's part of the stress for them, is the range of people who they're responsible for. I'm not sure, I don't know if we're going to get to directly talking about that. We certainly would like to be able to within the healthcare sector, we've been able to show that nursing homes that do a better job of protecting health and safety and supporting employee wellness have better resident outcomes, nursing home residents, that there's a connection. People talk about this in healthcare. If you take better care of your workers, they'll take better care of the patients. There's not a lot of empirical research yet. We had data that enabled us to do that within the nursing homes. It would be really interesting if we could look at that same question within the prisons. And it's possible that over time we could. I don't know. In our new healthcare study with the state and federal facilities, 2 of them are Massachusetts Department of Mental Health hospitals, and one of those has primarily what are called forensic patients, people who've been referred from the courts and the criminal justice system to the mental health hospital. So we're going to have some of those similar challenges there. What is the mixed role of the staff in situations where the people you're taking care of may simultaneously be hostile and may be a threat to your physical safety? It's about one of the most challenging situations I can imagine being in, and I don't have any easy answers at this point. But I think it's a really important issue. So thank you for raising it.
So this is not to cut off the conversation, but as you all know, there's back-to-back reservations for this room. So to take away from Dr. Punnett's discussion, we're going to transition to the lobby where we will take a salutatory refreshment break with one another to build coworker support for our own reduction of workplace stress. So can we thank Dr. Punnett again and join us? Join us in the lobby. Bring her a brownie. She's certainly alternative.